the first two drugs that we're going to talk about are Oseltamivir and Zanamivir. In order to best understand how these two drugs work, I think I need to explain a little bit of physiology. So I want you to imagine that you've got this host cell, and the host cell is what could be infected by a virus. And that host cell, on the surface of that cell, has what's known as the sialic acid receptors. So imagine, if you will, that inside of that host cell you've got a budding virus. The budding virus will be shown here in red. And as that virus grows and gets ready to leave the host cell and then undergo some viral shedding, it's actually going to move through the host cell and then locate on the surface. And at this point, that budding virus, which is now growing in size and pretty much ready to just jump off the cell and spread elsewhere, is connected to the host cell through those sialic acid receptors. Now, on the surface of the virus, there's a substance known as neurAMInidase. neurAMInidase's job for the virus under normal viral circumstances is to basically move its position and go find the connection between the virus itself and the sialic acid receptors. So what it looks like, and I've depicted it on this slide in green, is that the neurAMInidase goes over, finds the connection between the sialic acid receptor and the virus, and under normal circumstances, it cleaves the sialic acid receptors. And when it does this, it allows that virus to detach from the host cell and then undergo viral release, where the virus can then go on to infect more cells. So, if we go back to the original starting point of this slide, the way that Oseltamivir and Zanamivir work is that they are neurAMInidase inhibitors. So if you imagine, and I've depicted those two drugs shown as the little purple square, if you imagine Oseltamivir and Zanamivir coming in and just sitting on top of and blocking neurAMInidase, then neurAMInidase can never reposition itself and cleave the connection between the sialic acid receptor and the growing virus. So the mechanism of Oseltamivir and Zanamivir is to inhibit neurAMInidase. Now, something that's really important for you to know for test day, especially if we're talking about step 2, level 2, and beyond, is that these drugs are really only effective within 48 hours of symptom onset. So if you give them after that 48-hour mark, then it really doesn't do anything and it doesn't shorten the course of the virus. So only within those first 48 hours will this actually work. Now, how are you supposed to remember this? Well, if you look at the name of the mechanism and the name of the drugs, it kind of reveals to you what these drugs do. So you've got neurAMInidase inhibitors, and both of these drugs have ami in the name. So Oseltamivir and Zanamivir. And that AMI, or ami, matches up with the AMI in neurAMInidase. So neurAMInidase inhibitors are Oseltamivir and Zanamivir. Very, very high yield. Just remember the mechanism. Remember that you have to give it within 48 hours of symptom onset. Otherwise, it will not shorten the course of the influenza virus. And that's what this is used for, influenza. Now that you've understood the first two drugs, let's transition into our next group of drugs. So the next three that we're going to talk about are Acyclovir, Valacyclovir, and Famciclovir. And at the conclusion of this discussion, I'll mention one other drug that basically works the same way, but we'll reserve that for the end of this conversation. So again, in order to best understand how these drugs work, I need to show you a little bit of physiology and virology. So imagine you've got this host cell, and the host cell can be infected with viruses, and these drugs are going to treat things like HSV, VZV, etc. So if you want to treat those viruses, you're going to introduce these drugs. So imagine introducing one of these drugs. This could have been any of the three, but I've just written it as Acyclovir. So Acyclovir or Valacyclovir or Famciclovir will be represented by these purple squares. So you introduce the drug, and the drug makes its way to the host cell, and it gets inside of that host cell. Now, normally you've got an enzyme known as viral thymidine kinase. And what viral thymidine kinase does is, because of the viral infection, it usually acts as a phosphorylating agent because, as you'll recall, anything with kinase adds phosphate groups. So under normal circumstances, this virus will take substances And using this viral thymidine kinase, it'll add a phosphate to it. But when you introduce one of these three drugs, Acyclovir, Valacyclovir, or Famciclovir, the viral thymidine kinase will inadvertently add phosphate groups to the drugs instead of other building blocks that it could be using to help the virus replicate. And over time, what'll happen is one phosphate group will get added to any of these three drugs, and then it'll go downstream and happen two more times, and you'll get Acyclovir triphosphate, or Valacyclovir triphosphate, or Famciclovir triphosphate. Again, it doesn't matter which of these three we're talking about. The point is that viral thymidine kinase will add three phosphate groups to any of these three drugs. And once you have the end product, or the triphosphate form of any of these three drugs, there's no way that viral DNA polymerase can incorporate that into the growing viral chain. So what happens under normal circumstances in virology is that you've got this enzyme known as viral DNA polymerase, which comes along and adds more building blocks to the growing chain. But when you introduce Acyclovir triphosphate, or Valacyclovir triphosphate, or Famciclovir triphosphate, viral DNA polymerase simply cannot use it because that long phosphate tail terminates the growing chain. So I've shown viral DNA polymerase here in red, and because you've got a substance with three phosphate groups and a very long tail, you cannot incorporate it into the growing chain. So if I was going to summarize for you what the mechanism of Acyclovir, Valacyclovir, and Famciclovir are, I would say that these are guanine analogs that phosphorylate to terminate the growing chain by inhibiting viral DNA polymerase. So that's how these drugs work. And the thing that you should keep in mind for test day, two other really high yield points, is that one, there's a way that you can get resistance to these drugs, and two, there's a very high yield adverse drug reaction that you should be familiar with. So let's talk about that stuff now. First and foremost, the way that there can be some viral resistance is if the virus mutates thymidine kinase. So if you mutate thymidine kinase, then there's a chance that it won't add the phosphate groups to Acyclovir, Valacyclovir, or Famciclovir, and therefore you never get that 3-triphosphate form. It never terminates the viral chain, and therefore these drugs simply don't work. So if a virus mutates thymidine kinase, then you've got a chance that these drugs will be unsuccessful in your treatment. The very high yield adverse drug reaction that you should be familiar with is obstructive crystalline nephropathy. Okay, obstructive crystalline nephropathy. And we don't really have a great understanding of why this occurs, but if you think about this, the more triphosphate chains that you're adding to these, the longer of a substance that you have. And I always thought about this as you've got this really long-tailed substance that gets trapped inside of a nephron, and because of that, you get this obstructive crystalline nephropathy. If you think about the physiology of the nephron and how tightly woven it is and how precise all of the normal physiology of the nephron needs to be, well, it sort of makes sense that anytime you introduce a long-tailed triphosphate chain molecule, you're going to have problems carrying out normal physiologic function in the kidney. So the way that you can remember this is that your three drugs that have cyclo in the name cause a cyclone in viral DNA polymerase. So if you imagine a cyclone, a growing cyclone, as that cyclone spins, you've got the growing tail of the cyclone. And I put a little picture on this slide. If you imagine that as the tail spreads out in a circular fashion from the eye of the storm, that's your growing phosphate chain. So these drugs, Acyclovir, Famciclovir, and Valacyclovir, cause a cyclone in the viral DNA polymerase, so the viral DNA polymerase can't use it. The cyclone has the growing chain, and it just messes up all of the viruses that these drugs treat. So that's a very long-winded discussion about the three cyclo drugs. Again, remember the mechanism, so remember this slide, and understand the mutation of thymidine kinase can render these drugs useless. Remember the obstructive crystalline nephropathy because you've got that long triphosphate chain which will just plant itself in the nephron. And as your mnemonic, just remember that this causes a cyclone in viral DNA polymerase. Now, I mentioned at the start of this discussion there was one more drug that worked pretty similarly. And I'm just going to throw that in real quickly here. So you've got Ganciclovir. Basically, Ganciclovir is the same thing. It works the same way. It has all the same functionality, but it's just a 5-monophosphate that's formed by the CMV viral kinase instead of, as you see on this slide, the viral thymidine kinase. So slightly different enzyme, slightly different base molecule structure to it, but works pretty similarly. All right, so now you understand all of the cyclo drugs. Let's transition and talk about another 2 drugs that work very similarly. So with that said, we're going to now talk about Foscarnet and Cidofavir. So before I get into the discussion here, these are a little bit simpler to understand. They don't require as much of some background virology. So let's just get right into the nitty-gritty. The mechanism here of both of these drugs is that they inhibit viral DNA polymerase. And the major adverse drug reaction, and what's incredibly high yield to understand for USMLE and COMLEX, is that both of these drugs can cause a really significant nephrotoxicity. The major differentiating factor between these 2 drugs, and what I imagine that most of the test writers will go after, is which one of these drugs is a pyrophosphate analog and which one of these drugs has a special treatment that you can give with it to avoid the nephrotoxicity. So again, the mechanisms are the same, and what you might be asked to do is differentiate between 2 of them based on what I'm about to tell you. So some really high yield information coming your way right now. The first is that Foscarnet is a pyrophosphate analog, and that's pretty easy to memorize because phos is in the name. So Foscarnet is a pyrophosphate analog. On test day, they could ask you, they could say something like, an antiviral is given that inhibits viral DNA polymerase. They could show you some labs that show an elevated creatinine and BUN, and they're pointing you in the direction of one of these 2 drugs. And if the question then asks, which of the following is a pyrophosphate analog that meets the mechanism listed, the answer would be Foscarnet. So just understand that Foscarnet is a pyrophosphate analog. The other thing that's pretty unique about Cidofavir that differentiates it from Foscarnet is that even though both of these drugs cause nephrotoxicity, you can give something with Cidofavir called probenecid and also IV fluids to help mitigate that risk of nephrotoxicity. So in other words, if you give probenecid and IV fluids with Cidofavir, then the nephrotoxicity risk is a lot lower. So how do you remember this? Because that's incredibly high yield for test day. The way that I want you to remember this using my mnemonic is that Cidofavir has do and favor in the name. So do me a favor and give Cidofavir with probenecid and IV saline to prevent nephrotoxicity. So isn't that really cool, guys? I mean, do and favor are in the name. So do me a favor, give probenecid and IV saline with Cidofavir to prevent that nephrotoxicity. Really, really high yield because, again, Foscarnet and Cidofavir are so similar that the only differentiating factors between them is that Foscarnet is the pyrophosphate analog and Cidofavir can be given with probenecid and IV saline to prevent that nephrotoxicity. So if a test writer is really going to go after one of these, it's probably going to be one of these 2 high yield points. So make sure that you understand it and you'll do fine on test day. Let's talk now about Interferon-alpha. So imagine that you've got this host cell, and under normal circumstances, the host cell is just chilling, doing its thing. But when any host cell becomes infected with a virus, it actually releases interferon. So the thought by giving somebody interferon alpha is that you're just giving them more of something that the native cell would release anyway if it was infected. And interferon has a lot of different antiviral and actually anti-tumor properties to it. So if you imagine that this host cell becomes infected, which I'll depict here as this fuzzy red line, now the cell's infected, it's going to release interferons. So when you give a patient interferon alpha, you're just giving them basically an acute phase reactant that's already going to be released, which has antiviral properties. There's not much more to say about interferon alpha, so I'll leave it at that and let you just read a little bit more detail about it if you happen to be interested. But just understand that interferon alpha is something that's natively released anyway, and that's where its mechanism comes from. Now, the last part of this video today will be a discussion about the different hepatitis C drugs. And unfortunately, the hepatitis C drugs are really difficult to memorize because they have funky letters in them. They inhibit different parts of the hepatic pathway that the virus takes when it infects and damages a hepatocyte. So the best way to approach this is actually to draw out the hepatocyte and go through how hepatitis C infects the hepatocyte and what parts of that pathway these drugs can basically interfere with. So here's my gigantic hepatocyte, right? It's this square hepatocyte. Along comes hepatitis C, which you see here is that mucus-colored nasty virus. And there's different phases for how hepatitis C infects the hepatocyte. So the first phase is viral entry, that hepatitis C will just move inside of the hepatocyte. The second phase is fusion and uncoating. And then your third phase is translation and replication. The final phase is virion assembly, where you get that virus pretty much put together in its final form, and then it gets released where it can go and infect other hepatocytes. So this is the viral cycle for hepatitis C inside of a hepatocyte. And there are 4 different drugs that can be used to treat hepatitis C. And I'm going to talk about 3 of them on this slide. The 4th being ribavirin, which we're not going to touch on today. But if you're interested in that, go take a look in first aid or whatever question bank you like. It just happens to be one of the lower yield of these 4. So where these drugs really do most of their damage and interfere with this pathway is at step 3, translation and replication. The first 2 drugs that I want to talk about are cimeprevir and ledipasvir. So cimeprevir is a protease inhibitor, and what it's inhibiting is NS3A/4B. Now, as you'll see in this discussion, we use these abbreviations like NS3A/4B or NS5A, etc., etc., and they're just basically shorthand ways to write what these drugs are interfering with. But if you have to memorize something, you can just memorize that cimeprevir is a protease inhibitor, specifically at the NS3A/4B location. The other drug that inhibits replication is ledipasvir, and that one is the NS5A inhibitor. Now, both of these drugs are going to mess up the replication of hepatitis C in the hepatocyte, but they do it upstream of the third drug that we're going to talk about, which is Cidofavir. And Cidofavir is an NS5B inhibitor, which means that it interferes with the RNA-dependent RNA polymerase. Now, when you're studying, do I think that you need to memorize NS3A4B and NS5A and NS5B? No, I really don't think that you do. If you want to cram it into what limited brain space you have available, then by all means, do so. But if you're going to memorize one thing on this slide, I think you should memorize the name of the drug and what it's actually inhibiting. So for example, in the case of cimeprevir, I would memorize that it interferes with protease. And for Cidofavir, I would memorize that it inhibits RNA-dependent RNA polymerase. And ledipasvir doesn't really have a named enzyme that it's interfering with, so maybe for that one you could memorize NS5A. But the point is, I'm just showing you what information we know of at this point, and therefore you can memorize what you choose to memorize. But these are the 3 major drugs that are used in hepatitis C, again, along with ribavirin, which I'm not going to talk about today because these are really gaining the mainstream hepatitis C treatment. So we've got 3 drugs that treat hepatitis C, and what you should know is that basically, right now, the gold standard is to combine Cidofavir and ledipasvir. And the combination of these 2 drugs is actually what you may know as Harvoni. So Harvoni is pretty much, for all intents and purposes, it is a cure for hepatitis C. And again, as you can see by looking at the boxes here and the little case of pills, is that this is a combination of ledipasvir and Cidofavir. So again, these 2 drugs in combination is the gold standard for hepatitis C treatment, and this is the pathway showing you where they're working. So by combining these 2 drugs, you inhibit the NS5A part of replication, as well as the NS5B, which is specifically RNA-dependent RNA polymerase. So it's the combination of those 2 drugs that is really what's being used quite often today. Unfortunately, for patients, this combination is super expensive. So Harvoni is not terribly easy to get patients on, but I would be familiar with this combination because of the success that physicians have had treating hepatitis C with this combination. So guys and girls, that's it for today's video. I've gone through a lot of different drugs that are antivirals, and specifically we've talked about antivirals that don't treat HIV. So in this video, we've talked about drugs that treat influenza, HSV, VZV, CMV, hepatitis C, etc. I think that when you're studying antivirals, it makes sense to break them into 2 categories. the non-HIV and the HIV antivirals. So this video is the non-HIV antivirals, and at some point I will release an antiviral video that specifically focuses on HIV. But if you're trying to conceptualize this in your brain, it makes sense to study the drugs in this video in one sitting, and then once you're comfortable with these drugs, advance to the anti-HIV antivirals. So that's it. I really hope that this was useful to you. I know that this discussion happened somewhat quickly, but I do think that I broke this down in a manageable and conceptualized way. If you have any questions, feel free to comment in the comment section of this video. And once again, please remember to click the link on my Patreon page in the description of any of my videos, and please support the channel. Good luck.